Congenital heart disease is a really interesting disease for which, for many forms of congenital heart disease, especially the most complex ones, there didn't used to be any type of treatment or cure for it. Realistically, patients with the most complex forms of congenital heart disease, if they were born in the 1970s or even the early 1980s, they didn't survive. So this is a relatively young field in terms of the scope of medicine that we practice. Realistically, over the last 20 to 30 years, we've seen patients grow into adulthood. And what we realized is they have a lot of unanticipated issues that we didn't recognize were going to be important, not only to manage, but also to treat and potentially reoperate on as these patients went into adulthood. So I think there are two reasons this is really important. One is being able to better inform and understand parents of newborn babies how this congenital heart disease is going to affect their lives throughout their entire life. And the second part that's really important is to help manage adults with congenital heart disease so that they can continue to live a very fulfilling and satisfying life. They can have their own families, they can have any type of job, education, and most of all, they can feel like they're contributing to society. These are all things that become really challenging when you have a chronic medical problem. So the concept here at Johns Hopkins is that we offer care across the spectrum of life. That means everything from fetal care, diagnosis of congenital heart disease, even before patients are born, and complex decision-making in terms of how we're going to best manage that disease for each individual patient across the spectrum of their lives. So this includes follow-up, this includes management of disease. We have a group or a subset of patients who are newly diagnosed, either in their teenage years or in young adulthood. And the concept is that Johns Hopkins can afford us the ability to take care of these patients literally from before they're born until they're in their 80s. And that's something very unique. A lot of centers cannot provide those same opportunities. How do we do that exactly? Well, the number one thing is by combining the resources of both the Children's Heart Center here at Johns Hopkins, which has an amazing amount of talent, clinical excellence, and research endeavors, together with those of the adult hospital. And not only that, but also working with our colleagues in other fields, for example, OBGYN, so that women born with congenital heart disease can appropriately plan having a family. We combine that with the talent and the resources available to us from our social workers who can help with employment issues, early education plans for children, and on top of that, delivering consistently excellent medical care throughout their lifetime. Peds is a little bit different from adults, and in fact, we go through different type of training, and we're boarded, and that's where boarded by different subspecialties. And I think that's one of the areas where people kind of underestimate the need to combine all these resources. Pediatricians care for patients under age 18, whereas internal medicine doctors and adult cardiologists see what's typically called acquired cardiac disease, meaning you weren't born with it, but eventually you tend to acquire disease. Think of things like aortic stenosis, the most common valve disease that we see in patients as they age. The other disease that's very prominent is coronary artery disease, sometimes requiring bypass surgery or a stent to the heart. That's very different from patients who have congenital heart disease, a form of heart disease that they're born with. It's diagnosed by pediatric cardiologists, and it's managed by surgeons who have expertise in not only adult cardiac surgery, but also in pediatric cardiac surgery. So the knowledge to operate on everything from a 450-gram premature baby all the way up through adulthood. Once we combine these two resources, we're better able to take care of those tiny babies as they age into adulthood. And that's one of the real secrets here, is how to manage heart disease across the spectrum of a life, and how to understand how the disease that you had, that you were born with, and sometimes falsely thought you were cured from, is going to affect your life going forward. So transitioning into adulthood can be challenging for any individual child, and certainly a child who has a form of chronic heart disease. Realistically, we see that patients as early as 12 years old stop following with their cardiologist and are lost to patient care and follow-up. And it's these children who, as adults, then develop complex forms of heart disease or sequelae of their heart disease that tend to actually come back and resurface in adulthood. This means more ER visits. This means potential heart failure. This means potentially a need for a heart transplant. And so we look at this population, and it's an extraordinarily vulnerable population. Having the ability to see patients both at a children's hospital and an adult hospital, all under the same umbrella here at Johns Hopkins, enables us to smooth that transition for patients, enables us to better care for those patients and assure that they don't fall through the cracks. It means that they'll be cared for not only as children, but then they'll be comfortable with assuming responsibility and autonomy over their own health care as adults. Research is a really interesting field in medicine. We have clinical research in which we mainly focus on patient outcomes. For example, they have a disease that's treated, and we see how they do in the long run afterwards. We also have the type of research that's a bench work or scientific research. This is what you think about with pipettes and test tubes and cells and genetic research for patients. The area where these two intersect is something that is really appealing to us. The ability to carry a concept or a disease that we treat in a clinic, that we're able to potentially work on a solution and identify gaps and where we could have maybe improved the care of patients, and then to develop new treatment pathways going forward, whether it's based on genetic treatment, which is going to be the future of medicine, or whether it's based on just improving our clinical care with things as straightforward as delivering better social systems and care for our patients, early intervention for education for patients. Areas that are of my particular interest tend to be valve development for patients. Most of the valves we have commercially available are adult valves that we extrapolate and use in the pediatric population. However, one of our biggest challenges is developing devices that will grow with children as they grow. This will eliminate the need for a series of operations on children, which are not only interrupting their lives, but also potentially threatening their lives. The concept of being able to put together a research core here at Johns Hopkins that involves all three areas of research is something unique and something that's truly supported by the institution. So I think one of the things about cardiac surgery that really excites me is the ability to work with other people, not only on the heart, but also other areas, which is really interesting to me. So cardiothoracic surgery has afforded me the opportunity to really work in multidisciplinary teams. You would think it's only heart surgery, but for example, complex airway surgery in babies who are born with a small airway and have difficulty breathing. Patients who have tumors in their airway, very rare in pediatric cases, but certainly need expert care in order to get treated. Things like conjoined twins. We see them rarely, but having the expertise to be able to work with a multidisciplinary team of colleagues from various areas of surgery and be able to combine our resources and our talent in order to treat patients and give each individual patient the best possible outcome. The same for patients with complex cancers of the chest. It's a privilege to work with some of my colleagues to develop aggressive treatment and pathways for these patients.